Thanks everybody. Thanks for joining this month's QI community webinar for the month of February. My name's Tony Lemke. I'm a GP in Northern New South Wales and Chair of Faculty at the Improvement Foundation. And I'm happy to say we're joined today by Katrina Wilson, who's the Integrated Care Manager at the local health district in Northern New South Wales. You're the Integrated Care Manager. Tell us about how you see integrated care, why is it important, and what's your role?
Thanks, Tony. Integrated care is getting traction right around the world because we're seeing a change in demographics and patterns of illness. Hospitals arose from a time where people had infectious diseases, acute illnesses, and sometimes trauma, so that was a logical place for healthcare to be provided. Now we're seeing people living longer with a prevalence in chronic diseases, non-communicable diseases. So these people have quite often more than one chronic condition, and they quite often have complex care needs because of their psychosocial situation. So they actually need a team of people all bringing different skills to the table to actually care for them and their families and their carers. We're still geared in many respects to providing isolated episodes of care in hospital without actually recognising that patients do a lot of self-care, and when they do need care they actually go to their general practitioner or other practitioners in the community and use hospitals as a last resort. So integrated care is about bringing people together in a coordinated way to provide care over a long period of time, working with the patient around things that matter to them, working on their quality of life, and really trying to help them to stay out of hospital. So I became involved in integrated care when the New South Wales Health Ministry released its integrated care strategy, and what it was aiming to do was provide seed funding to trial models or ways of better providing integrated care to communities in different areas. And in the North Coast, we have a high ageing population and therefore a high number of people with chronic and complex conditions, and that's where we decided to start our work with integrated care, even though it is applicable to other younger groups, for example. And the big difference is that we're looking at all chronic diseases and the level of complexity, so including mental health, as well as what people would consider the more common chronic diseases such as cardiac, respiratory and chronic kidney disease.
Thanks, Katrina, and certainly developing a health system that works as one that provides integrated care is a focus internationally. All health systems in the world, from what I can see, are trying to crack this nut. Now you're responsible for that in your area. Congratulations for that. After some discussion, one of the things you decided to undertake was a collaborative, an integrated care collaborative. So why did you choose a collaborative, and what did you mean by that?
So with the collaborative is really a quality improvement methodology that's used to support sustainable change. It's previously been used where there's evidence to support changes, but we decided to try this in integrated care because it's a way of actually bringing a large number of people together, working towards the same goals, and to stimulate ideas about how we can better improve patient care.
So as you say, collaborative is often used when there's good, strong evidence for the behaviours that you want people to do, and you're trying to encourage spread and sustainability of change using quality improvement approach. In this collaborative, you're looking for new and innovative ways to deliver integrated care, and perhaps, Katrina, looking for the grassroots approach where people come up, the clinicians and the patients on the ground come up with ideas rather than have them decreed from on high. Is that the way you were thinking about this?
Definitely, definitely. I mean, you know, clinicians work very hard every day, and they often think, oh, if only we could do things differently. You know, we had this great opportunity to actually bring all of these clinicians together, and it was well supported by the organisations involved in our integrated care strategy on the North Coast, and then that's the Primary Health Network, the Local Health District, Aboriginal Medical Services and New South Wales Ambulance. So I think that leadership is incredibly important because clinicians then felt actually supported to try new things in the workplace, and if it didn't work then they could try something else, and that's the whole idea about doing small tests in a clinical setting to say, I've got a great idea, let's try this, and if it works, that's great, let's share it with everyone else so that they can try it as well. And sometimes those things get traction, sometimes they don't, but it really stimulates clinicians to think in different ways and to interact with their colleagues in different ways.
To help in the planning, I understand you had that steering group that you've just mentioned, all those different organisations, and then you formed an expert reference panel, which is the traditional collaborative first step to come up with some aims, some measures and some change principles. What was the broad aim of the collaborative, Katrina?
What we wanted to do, Tony, was actually form integrated care teams around a cohort of patients who were identified by clinicians, mainly by general practice, and that cohort of patients were either those that were likely to end up in hospital if they weren't well supported in the community. They might have had multiple complex conditions or multiple chronic conditions, or they might just benefit from integrated care because of their motivation, for example. So the clinicians actually identified these patients. The challenge for us was to get the clinicians to work out how to work together to actually support the patient's needs and the patient's preferences, so that patient choice was very important.
Okay, so you had the aim to have a cohort of nominated patients being managed by a team of clinicians working together to come up with new ideas, and I think there was a number set around 200 of those, and then you came up with some change principles that would inform, general principles that would inform the decision making and help us group together any ideas that were produced by the practice teams. Katrina might let us know the 5 change principles that were developed for the collaborative.
Yes, thanks, Tony. I've already alluded to the first one in terms of the aim, so identifying the complex cohort. Within general practice, each practice or Aboriginal medical service maintained a register of these people so they could track them, and at the LHD we actually had a register as well so that we could monitor any hospital activity that might happen with these patients. Then the second one was about improving your own systems. A lot of work would happen in general practice around what are the things that they actually needed to do with these patients to improve their access to care. So that might actually, be something like having them on a priority list. The third one was working as a team member, and that could be within your own team, within your own workplace, or working with other colleagues right across the system and including the patients and their families to form wraparound care for these patients. There was a big focus on improving patient self-management, and then the fifth one was about improving the wider system, and that's where we actually look for opportunities about how we can actually move the ideas that proved fruitful in the collaborative right across the system. The important thing about the change principles is that we weren't really prescriptive about where people wanted to start. So a lot of people actually started with building relationships with other professionals that, that from services that they might not even had known existed, but yet they shared common patients. So we actually saw a bit of flexibility in terms of it wasn't very prescriptive as to where people could start. It's just where they had ideas that they wanted to trial, and then they built on those.
Thanks, Katrina. So then as in a traditional collaborative, you decided to have the 3 learning workshops. Was it easy to find a time when hospital clinicians, community members, ambulance men and general practice teams could all come together? Was that straightforward?
It didn't follow the usual way, I think, of collaboratives when they were just, you know, held within one organisation. So that required some really strong leadership and some creativity from management to really put in a big effort to get facilitate clinicians getting together, and patients. We had patients involved at some of the workshops, in getting them together so that they could share ideas and get to know one another and more actively form teams around the patients. So it was actually a real challenge.
What were some of the highlights of what happened at the workshops for you?
I think really the relationships and forming new ways of communicating with each other and with patients, developing, which really started to build the culture change that we were wanting to see. And that really started from the first workshop. So we actually saw the collaborative as really kind of stimulating the system, with passionate clinicians and managers who wanted to see this work, starting to form new relationships, new ways of working. And that was really what we saw at the first workshop, the seeds of that happening, but also a little bit of how are we going to do this, because we were non-prescriptive in the way clinicians had to work, and that was very different for us, because usually we're used to having models of care that we're then required to implement, but there was no real precedence for integrated care. So a lot of freedom in the way we did it, and really looking for innovation.
That was brave, Katrina. You said to the participants, we don't know all the answers, but we know that given goodwill and permission, you will go and find them, and you set them out on that task. And you said there were patients included at the workshops.
Yes, we had we held workshops in 2 different locations, and we had patients presenting their story. Incredibly powerful. You could hear a pin drop. We also had a very skilled facilitator, really drawing out what the issues were, but a very captivated audience. So it's very powerful to have patients telling their stories, and it also stimulates the thoughts of others in the room about, you know, how can we do this better, or how can we do this differently.
So I'm going to ask you now, Katrina, about some of the change ideas that were developed by the participants and what they've gone into. Were there many models for improvement submitted? Did you get a number of change ideas?
We did. We had more than 250 ideas for change generated by clinical teams, and they were across a whole range of settings, primary care, across both primary care and hospital or community health, and within the LHD. And a lot of those were around relationships, having multidisciplinary team meetings. Some of the ideas, interestingly, were about making it easier for the next clinician to do their work, and one that really springs to mind was improved screening of cognitive state in general practice, and then a method for communicating that so that if the patient presents to hospital, they've got a baseline. And we did a lot of work around improving number of patients with advanced care directives. And a really interesting thing was the engagement of mental health, working with what we call mainstream, so that we really had a good understanding of, or we developed better understanding even within the LHD of what services there were and how people can work together.
It must have been very interesting seeing teams that you would expect work together, but we know don't. Community nurses and general practitioners and mental health practitioners all in the one room talking about the patients. That must have been an important trigger for changing relationships between practitioners.
Yes, yes, it's incredibly powerful, and sometimes some of the ideas that they come up with are very simple, but they can have such broad-reaching effects. One that springs to mind is something that we did around notifying general practitioners of when their patients were admitted to hospital or when they were discharged from hospital, and that was a little trial we did with our IT department, which really got traction. And is now being taken up by the state, and we're looking at developing a second version of that. So it just means that general practitioners are informed of when their patients go to hospital. They can provide relevant information that the hospital might not have access to. They can be involved in discharge planning, and similarly we can make sure that the patient has timely follow-up with their general practitioner with all the right information in place.
Well, in fact, I think you've started monitoring the timing and quality of discharge summaries when patients leave hospital.
We have, yes, we've actually started doing that, and people actually didn't realise what the delay was until we actually started measuring. It's one of the powerful things about measuring, and you know, we've seen some modest improvements in the timeliness of discharge summaries, but we've now got a large piece of work that's following on from that, despite the fact that the formal part of the collaborative is finished, where we're focusing on the quality of the discharge summary and the safe transfer of care between acute and primary care and vice versa. So that can only improve the people's or clinicians' work, but also benefit the patient in a significant way.
And I think I heard you say, Katrina, that there were meetings between groups, lunchtime meetings between people working in this one community nurses and GPs that perhaps traditionally might have happened many years ago but hadn't happened for some time, so new relationships forming. And I think I heard you say that one of the hospitals decided to put the name of the general practitioner on the top of the bed alongside the attending VMO to remind the hospital team that the patient existed in the community. Also, fantastic ideas coming through. One of the challenges, Katrina, you said at the start was that you wanted to have 200 patients nominated to be managed in this integrated way, rather than using a tool to pick patients out of the hospital system. You asked the general practitioners to identify patients that they thought would benefit from this approach and were at high risk of hospitalisation. Was that a successful approach?
Yes, it was. The general practitioners were quite accurate in predicting which of their patients might end up in hospital, and I think it was over 50% of the cohort did have contact with the hospital system during the time of the collaborative, which was a 9-month period. So yes, that was an effective way of identifying those high-risk patients. I think the challenge for us now is to actually work out what we need to do with the rising risk patients as well.
And you mentioned that there was some work on making sure these particular patients had advanced care directives. Has that progressed beyond the collaborative, that end-of-life care discussion?
Yes, yes. One of the challenges we had when we first started with the collaborative was getting medical specialists involved with the collaborative. But as we're seeing the culture change across the system, clinicians who traditionally have just confined themselves to the hospital are now focusing in on ideas where they think, well, we could really focus on this area, and one of them is end of life. And there's a big group at one of our base hospitals that meets on a regular basis, and working with general practice to see how we can provide better care at the end of life for patients in hospital and also in the community in partnership.
And as part of that, I understand that the traditional winter bed strategy meetings has changed in its nature for this coming year.
Yes, there's been an idea put forward that this year we engage general practitioners in our winter bed strategy. That's an idea at the moment and soon to be progressed. So something that we haven't done in the past. So it'll be really interesting to watch this space.
And Katrina, we have been approached also about a new scheme the hospital administration developed, whereby the new interns attached to the hospital are also, as well as doing their normal junior medical officer work, will remain attached for a whole year to a particular general practice and have an input into a patient from that practice when they're in hospital. They'll be the eyes and ears of the practice in the hospital and be able to contribute feedback to the general practices about the course of the illness for the patient and also participate in the discharge planning. What an exciting idea, and it's come out of this change in culture that you mentioned through the collaboratives. One of the change principles, Katrina, was about supporting patients to better manage their care. Was that progressed through the collaborative, and has there been any follow-on through that sort of work?
Yes, there's a lot of work that's happened around self-management. I mean, that's it's one of the core principles of chronic disease management. We've done a lot of work around things such as health literacy. We've developed a health literacy framework so that the patients can better engage in decisions around their care because they have better understanding. That's something that we're working on at the moment, not only in terms of, for example, written information that we might provide to patients, but also working with clinicians and teaching them new skills in working with patients to ensure that they have better understanding of their conditions and how to manage their conditions.
I like the way, Katrina, when you say we're working on this, you mean the local health district and the primary health network. It's become a natural way of working in this collaborative space. Is that fair?
It has, yes, and yes, that's right, and not to forget our Aboriginal medical services as well. So yes, we do use that terminology, and that's very important because we've got an implementation group which is supporting all of this work, but it's really, as you said at the beginning, we're actually supporting clinicians to make changes at that clinical level as well.
One of the aims, Katrina, that we at the start was to make North Coast New South Wales the best place in the world to receive care for a chronic condition and one of the best places for practitioners to deliver care. You've used it in a couple of centres. Has it been successful enough that the administration is looking to support it in other towns in your region?
We're certainly looking at that at the moment. We didn't do this right. We didn't conduct the collaborative right across the local health district. It has proved successful, particularly in terms of generating a lot of activity in integrated care. So it's been a real catalyst for us. We had a time-limited period where we had the structured part of the collaborative, and now we're still seeing ideas being generated well after we finish that formal part of the collaborative. So it's been a really positive approach for us. So certainly we'll be using quality improvement approach going forward and moving into other areas.
Yes, so as Integrated Care Manager, the work is incomplete and you'll have a job for some time working there, Katrina. It sounds like it's been, from what you've said, that there have been significant benefits from taking this quality improvement approach. In summary then, what would you like to say? What do you think are the main benefits?
I think the culture change is palpable that we're feeling, and I think the empowerment of clinicians to really get together and work in meaningful ways has been great. And I think that culture change is also in management and seeing their role changing from providing less direction and more enablement, I suppose, enabling their clinicians to work in new and innovative ways.
That's a fantastic message. Thank you for sharing the work you've done there in Northern New South Wales with us and the participants in QR community today. We look forward to hearing how you progress and the other good ideas that come out of your future work, and with your permission perhaps we'll revisit this later in the year or early next year to see what other good ideas other areas can steal shamelessly from. Thanks very much, Katrina. Our next QR community webinar will be in March. The topic yet to be announced. Sarah will be sending out the information about that. We thank you all for participating today. A great thanks to Katrina Wilson from the Northern New South Wales Local Health District, where she's Integrated Care Manager. And we look forward to speaking next time. I'm Tony Lepke, and thank you very much.